Today we'll cover bone tumors, including benign, malignant, metastatic types, their pathophysiology, diagnostic findings, medical management, and nursing care. Introduction. Bone tumors can be either primary, meaning they originate in the bone, or secondary, which are metastatic tumors that spread from cancers elsewhere in the body, like the breast, lung, or prostate. Neoplasms may arise from connective tissue, marrow cells, cartilage, muscle, nerve, or vascular tissue. Benign bone tumors. Benign tumors are more common than malignant ones. They are usually slow-growing, well-circumscribed, and encapsulated. They rarely cause death, but they may still cause discomfort or pathologic fractures. Osteochondroma is the most common benign bone tumor, often appearing as a large projection near the ends of long bones, especially the knee or shoulder. Bone cysts may be aneurysmal, expanding, painful masses, or unicameral, single-cavity cysts in young patients, often in the humerus or femur. Osteoid osteoma is a painful small tumor in children and young adults. Enchondroma develops from cartilage and often occurs in the hands or long bones. Giant cell tumors may remain benign for years, but can invade local tissue and later transform into malignant lesions. Malignant bone tumors. Primary malignant tumors are relatively rare. They arise as sarcomas or from bone marrow elements like multiple myeloma. Osteosarcoma is the most common and deadliest. It affects children, adolescents, and young adults during periods of rapid growth, but can also appear in older adults with Paget disease or after radiation. Common sites include the femur, tibia, and humerus. Chondrosarcoma is a malignant cartilage tumor, usually seen in middle-aged and older adults. Its prognosis depends on tumor grade. Low-grade forms grow slowly, while high-grade ones spread quickly. Ewing sarcoma and fibrosarcoma are other aggressive forms. Metastatic bone disease. Secondary tumors spread from other cancers are actually much more common than primary bone tumors. Common sites that spread to bone include the kidney, lung, prostate, breast, ovary, and thyroid. Metastatic lesions may be lytic, causing bone destruction, or blastic, causing bone overgrowth. They are often found in the skull, spine, pelvis, femur, and humerus, and frequently involve multiple bones. Pathophysiology. Tumors disrupt the normal balance of bone remodeling. Malignant tumors invade and destroy adjacent bone tissue, weakening structure and leading to pathologic fractures. Benign tumors generally grow symmetrically and press on nearby structures, but they don't aggressively destroy bone. Clinical manifestations. Patients may have pain, ranging from mild to severe and persistent, palpable mass or bone deformity, fractures with minimal trauma, weight loss, malaise, or fever. Spinal metastases are especially dangerous because they can cause spinal cord compression, leading to neurologic deficits such as weakness, gait disturbance, or loss of bladder and bowel control. Assessment and diagnostic findings. Diagnosis involves imaging, X-ray, CT, MRI, PET scans, biopsy for histology performed with extreme care to avoid seeding tumor cells, blood tests, ALP elevation with osteogenic sarcoma, hypercalcemia in metastatic disease, chest X-ray to check for lung metastasis. PET scans are valuable for whole-body staging, especially in metastatic disease. Medical management. Primary bone tumors, treated with surgery, chemotherapy, and radiation depending on type and sensitivity. Limb-sparing surgeries are preferred when possible. These may involve prosthetics, grafts, or arthroplasty. Chemotherapy is used pre- and post-operatively to reduce micrometastases. Secondary bone tumors. Management is usually palliative, focusing on pain control, stabilization of weakened bones, and maintaining quality of life. Surgical stabilization, bone cement, or joint replacement may be used to prevent fractures. Bisphosphonates and rankle inhibitors are important in slowing disease progression and reducing skeletal complications. Nursing management. Nursing care begins with a thorough assessment, history of symptoms, pain management strategies, and coping skills. Physical exam with careful palpation of the mass, assessment of neurovascular status, mobility, and ADLs. Pain management. Bone pain is often severe and challenging to treat. Use analgesics, radiation, or systemic isotopes such as strontium for multiple metastases. Mobility and fracture prevention. Handle and support affected extremities gently. Educate on weight-bearing restrictions, safe use of assistive devices, and strengthening of unaffected extremities. Splints or surgical fixation may be needed to prevent fractures. Emotional support. Patients and families often struggle with fear and uncertainty. Nurses should provide emotional support and, when needed, refer to counseling or spiritual care. Monitoring and complications. Delayed wound healing. Use aseptic dressings. Prevent pressure injuries. Ensure good nutrition. Osteomyelitis and wound infections. Prevent with prophylactic antibiotics and aseptic technique. Hypercalcemia. Watch for weakness, nausea, constipation, arrhythmias, or confusion. Treat with IV fluids, diuretics, bisphosphonates, or denosumab. Encourage ambulation to reduce calcium release from bone. Education on medications, dressing changes, weight-bearing limits, and therapy programs. Teach patients and families how to recognize complications like infection, fracture, or hypercalcemia. Coordinate community and home health resources for ongoing support. Long-term monitoring is essential for detecting recurrence or progression. For metastatic disease, hospice and palliative care may be appropriate. Conclusion. Bone tumors can range from benign lesions to aggressive malignant cancers. Nurses play a critical role in assessment, education, emotional support, and complication prevention. The ultimate goals are pain relief, preservation of function, prevention of fractures and complications, and improving quality of life for patients and families.